This morning we have one of our local people, Jessica Patzer, is giving us a presentation entitled An Approach to CPET, Lessons Learned from Adult Congenital Patients. Jessica, all of us know, she's been here since, I think, medical school. Jessica originated in Calgary and then did her undergraduate degree in mechanical engineering, and has the story of becoming a mechanical engineer at the University of Alberta and moving back to Calgary and not working for an oil company, which I think may be the only person I've ever heard of doing that. Anyway, she went through general cardiology here, went off to Toronto to do adult congenital training, and has now returned, is currently in an echocardiography year, and is hoping to join us as an adult congenital doc come the fall. So I will hand over the floor to you, Jessica. Look forward to your talk. Thanks.
Good morning, everyone. Thank you so much for that warm introduction and for inviting me to talk about an area that's very near and dear to my heart, adult congenital heart disease, but not only that, their assessment with cardiopulmonary exercise testing. Perhaps a misleading name, cardiopulmonary exercise testing, it seems to have a very niche role within general cardiology. I'll admit, prior to my ACHD fellowship, I had a very limited understanding of the test beyond VO2 max. But I came to see what an incredibly powerful diagnostic tool it can be. My hope with today's lecture is to review the indications for CPET, as well as review the relevant cardiac and pulmonary physiology to help understand these tests, provide an approach to CPET interpretation, practice cases through several that I'll have for you, examine the unique lessons learned from ACHD patients, and provide a framework for exercise prescription in the office. So I don't need to belabor this point, but we all know the benefits of exercise. Recommended guidelines say 30 minutes of moderate intensity activity 5 to 7 days a week, which has been associated with a drop in blood pressure, changes in cholesterol profiles, reduction in obesity, particularly at higher endurance levels, and improved glycemic control, increased quality of life, both physical and psychosocial, and hospital admission. And then finally, improved physiological benefits from improved sleep, decrease of stress and anxiety, and it's as effective as some of our more powerful antidepressants. Despite the numerous benefits of exercise, though, our population is sedentary. About 1 in 4 people are inactive, and that increases in more developed countries and those with a higher socioeconomic status. And only a small percentage meet guideline recommendations for exercise. Currently, men are doing better than women in this regard. And all of these studies looked at pre-pandemic patients, and in my anecdotal experience of ACHD patients, despite patients having more free time during the pandemic, activity levels plummeted. You couple this with a high percentage of the population having underlying cardiac or lung disease, and we have an epidemic of worsening exercise tolerance and dyspnea. And so how do we sort out what is just deconditioning versus true disease or progression of existing disease? And while clinical acumen can get you far, formal CPET testing is sometimes required. So most patients with cardiac or respiratory problems have symptoms that are worse on exertion, and thus it makes sense to do measurements when these systems are under stress. A cardiopulmonary exercise test assesses the reserve capacity of the body, particularly in terms of its ability to deliver oxygen to the peripheral tissues. There's a difference between bike and treadmills, where the bike is better for patients with limited mobility and there's less motion artifact, but it could be not the right modality to examine when you have someone with a pacemaker whose heart rate is in part reliant on the motion of the accelerometer. In terms of indications for CPET testing, its help is to differentiate between cardiac and lung disease, evaluate dyspnea, quantify fitness, help with surgical risk stratification and transplant assessment, and then provide prognosis. To me, CPET utility is really particularly useful in determining how much of the patient's symptoms, usually dyspnea, are related to their underlying cardiac pathology, be it valve disease, systolic dysfunction, or an anginal equivalent, versus their underlying lung disease. And within the same patient, it can be very useful to correlate non-specific symptoms with quantifiable parameters, or correlate a change in function, let's say new severe pulmonary regurgitation, to functional capacity in asymptomatic patients. And in ACHD patients, exercise plays a particularly useful role. 1 in 150 adults have congenital heart defects. And this is a 50% increase in the adult patients over the past 10 years. So when I started my fellowship or my training to my current year of fellowship, and it's in part improved from survival of these very complex lesions. The young patient population, many of whom desire to be physically active, but are not physically active due to fear from either themselves or their support members, having been told they are unable to participate in physical activity, perceptions that they're too weak to keep up with their peers that start in childhood and extend to adulthood, or symptoms of which there is a high burden. And studies have shown that exercise is safe for most ACHD patients, even those with NYHA class 2 or 3. There are some patients, though, despite this, who are very active. And here on the right, you see Sean White. He's an Olympic snowboarder, and his underlying congenital lesion is tetralogy of Fallot. In addition to the significant anatomical variations between these patients, they have significant comorbidities. Up to 44% have abnormal lung function, and an additional 14% have non-cardiac abnormalities, which we are starting to recognize abnormal muscle development in many of our Fontan patients. And so we really need an approach to how to assess these patients, manage their preconceived notions of exercise, and guide their activity going forward. And CPET is really at the heart of this. CPET also plays a role in transplant assessments, and our heart failure physicians are no stranger to this. It's only one component of candidacy for heart transplant, and while it alone does not constitute the need for heart transplant, it's useful in conjunction with a clinical assessment. Here I have shown the values for non-CHD patients with an absolute value of a VO2 max less than 10, and we'll talk about that with what that value is a little bit later, provided anaerobic threshold was achieved is one of the indications for listing. And then relative indications depend on whether or not the patient was on beta blockers, and if it was a submaximal study, there are other parameters that we look at. Switching gears now to review the general CPET parameters, their physiological principles and measurements used in testing. You will recall gas exchange occurs at the alveolar level in the lungs, with the pulmonary capillaries exchanging CO2 for O2. And when it comes to diffusion, it's tempting to think of carbon dioxide and oxygen as similar, but they're very different in terms of their properties. CO2 diffuses easily from the air to the liquid, whereas oxygen does not make that transition as easily. The key parameters that we'll be looking at the study are minute ventilation, so the total volume of air in and out of the lungs in a minute. The VO2, or the volume of oxygen taken up from the lungs into the blood, volume of carbon dioxide produced by the body and exhaled through the lungs, oxygen saturation, and then the heart rate. And from these 5 measurements, there are several important derived parameters. As oxygen comes in and CO2 goes out, the 2 volumes are measured, and the ratio between these 2 is defined as the respiratory exchange ratio. The oxygen pulse is derived from taking the volume of oxygen taken up by the lungs and dividing it by the heart rate. And so it's really describing the amount of oxygen taken up with each heartbeat and is a surrogate marker of cardiac output. Further derived parameters include anaerobic threshold, or AT, which is the point in exercise beyond which the oxygen demand for the muscles exceeds the amount delivered to them. And here the body starts to supplement aerobic with anaerobic metabolism. Acidemia develops when the production of carbon dioxide and the generation of lactic acid exceed the buffering capacity of the body. And the respiratory compensation point is the point beyond which there is a respiratory compensation for this metabolic acidemia, as the reduction in pH stimulates ventilation. A quick recall that there are several sets of muscles required for ventilation. So you can see the muscles listed as under inspiratory, which are your diaphragm, your external intercostals, scalenes, and sternocleidomastoids. And then your expiratory muscles are really related to those internal intercostals and your abdominal muscles. Going back to internal medicine, we'll quickly review CPET as this is a big part, or pulmonary function testing, as this is a big part of CPET. Total lung capacity, or TLC, is the volume of air in the lungs after a maximal inspiration, and it's usually between 4 to 6 liters. It may be increased in patients with obstructive defects like emphysema, and decreased in patients with restrictive abnormalities such as chest wall kyphoscoliosis or scar tissue from prior cardiac surgeries. The vital capacity is the total amount of air exhaled after maximal inhalation. And while it varies according to age and body size, it really reflects the ability of our patient to breathe deeply and reflects inspiratory and expiratory muscle strength. It's usually classically reduced in patients with restrictive. The residual volume, or RV, is the volume of air remaining in the lungs after maximum exhalation. Usually this is just over a liter, and in obstructive lung disease with incomplete lung emptying or gas trapping, this value can be significantly elevated. The tidal volume, or VT, is the amount of air typically inhaled or exhaled during one respiratory cycle. And while it's normally about 10% of vital capacity, it can increase up to 50% on exercise. Finally, the FRC is all of the air remaining in the lungs at the end of a normal exhalation. A quick refresher, pulmonary function testing is used to assess for obstructive and restrictive disease. The forced vital capacity is asking a patient to inhale maximally and then forcefully expire all of the air as quickly as possible. And FEV1 is the volume exhaled in the first second, and usually is about 80% of the total volume. You can see those loops of expiration flow volume on the right-hand side. Age and height are predictors we use to guide assessment, but unfortunately does not take into account ethnicity, which can significantly influence things. In obstructive lung disease, this ratio between the two parameters is less than 75%, and it's usually related to conditions like asthma or COPD, and the diagnosis is confirmed by a high residual volume. It can reflect weak expiratory muscles and poor effort. In restrictive lung disease, both the FEV1 and FVC are reduced in a proportional manner. It's confirmed by a low DLCO, and it occurs in patients who have reduced lung compliance from either parenchymal or chest wall processes, or have weak inspiratory muscles. It can also be affected by things that take up space in the chest wall, so pleural effusions, pneumothoraxes, or masses. Then DLCO really speaks to what is going on at an alveolar level and the health of the lung parenchyma. Pathologies that reduce gas exchange, such as a lung resection or emphysema, will reduce this parameter, or parameters that increase membrane thickness, such as pulmonary fibrosis, pulmonary edema, or pulmonary arterial hypertension, will also affect your DLCO. A quick review of pulmonary function interpretation. But obstructive lung disease that shows a normal FVC or slightly reduced, as well as a reduced ratio between the two, and a normal or reduced DLCO where the other parameters are increased. Classically, that residual volume needs to be increased. Restrictive lung disease, you see reduction across the board, but proportional between FEV1 and FVC. That's when it's lung causes resulting in restrictive physiology. When it's chest wall, your DLCO will be normal. And then for pulmonary vascular disease, the classic hallmark is a reduced DLCO. Next, we'll go through the normal stages of cardiopulmonary exercise testing. The patient has their leads and blood pressure cuff placed, their peripheral oxygen saturation monitor attached, and then they're positioned on the bike or treadmill, and the mask to monitor their ventilation is attached. Just putting the mask over the face can alter the breathing pattern. So a minute or two is allowed for the patient to acclimatize and establish a new baseline. Next, we go to unloaded cycling or walking. And once the patient starts to move the ergometer or start walking, there's also another change in breathing pattern because the patient's anticipating having to perform additional muscle work. And so we give another few minutes for the patient to settle to establish a new baseline. There's a progressive increase in workload up until peak maximum exercise, and the resistance slowly gets harder. At some stage, the patient will be unable to keep the pedals turning and will need to stop. And it's important to note what's limiting further exercise, just as we would within a treadmill study or stress echo. And then recovery is typically observed for 10 minutes with a period of gentle unloading to help prevent sudden falls in blood pressure. So now that we're familiar with the underlying components of the CPET, let's dig into the various parameters to help us interpret these tests. most familiar CPET parameter, or VO2 max, is the volume of oxygen taken up from the lungs into the blood. And because of the closed loop of the mouthpiece, we are able to measure the oxygen uptake utilized by metabolism, primarily via the mitochondria in the muscles. VO2 max is the highest value that the VO2 is reached during the test and reflects the aerobic capacity. VO2 is often used ubiquitously for VO2 max. This is usually displayed at in the top right panel of a 9-panel display, which you'll see in later examples. And it can be measured as either milliliters per minute or standardized for weights. Most of the studies that use VO2 max as a predictive tool use the weight-based measurement. And it should be noted that patients with lots of peripheral edema, their dry weight should be estimated, otherwise their VO2 max will be falsely low. Similar for patients who are obese, lean body mass is what should be used. Also influenced by age, gender, and to a lesser extent, height. In normal individuals, the VO2 max is going to be greater than or equal to 80% predicted. Some other studies use standard deviations around the mean, with the bottom 20% being poor performance, or the bottom 5% being very abnormal, whereas others use absolute values, and a value less than 20 is low and 10 is severe impairment. So what causes a low VO2 max? If there was premature termination of exercise prior to the patient making their maximum effort, such as in patients who have underlying arthritis, this can be a cause of a low VO2 max. Sometimes it's just a couch potato, an unfit individual. And then in patients with heart disease, the circulation is not actually able to get enough oxygen to the muscles. And in lung disease, there's insufficient capacity to get oxygen into the lungs or from the lungs into the blood. And this has several implications. So a lower VO2 max is associated with earlier death in the general population without other major illness. And in patients with cardiopulmonary disease has poor outcomes in those patients. It's also closely related to death or major complication in cardiac and thoracic surgery. And this correlation holds in other types of surgery, but to lesser degrees. But it should be noted that ACHD patients have normal VO2 maximal parameters related to their anatomy and corresponding physiology, and this varies compared to normal subjects. A study by Dr. Kempe in 2012 examined data from just over 4,000 patients, half of which had studies done at the local center in London, and half were from 23 other papers. And it really allowed for the comparison of individual patients' exercise capacity to that of their anatomical peers. And not unexpectedly, patients with severe congenital heart disease, so your Eisenmengers, your Fontans, had reduced VO2 max relative to normal patients. But even patients with relatively quote unquote simple lesions like coarctation, tetralogy of Fallot, or transposition in the great artery post-arterial switch, VO2 max was slightly reduced in these patients compared to normal values. And so just zooming in on that graph to show you a bit better, the vertical lines here actually represent different percentiles, the bottom line being 10, 5, then 50, 75, and 90%. And the VO2 max here is reported when indexed for weight. The reference breaks down differences into genders as well, but just for display, I've shown one parameter. And then just a reminder, with those simple lesions, there's a significant change as well. So in the example I have here, we have transposition of the great arteries, status post-arterial switch. So their pulmonary artery and aorta was swapped into the normal position. And even those patients have an abnormal exercise capacity. And so it really behooves us to look at patients with congenital heart disease relative to their anatomical peers. But a CPET is so much more than just VO2 max. And while it's a very powerful metric, it's really analogous to looking at an ECG only for the patient's heart rhythm. There's so much more information to discover, and I'm hoping that in the next slides we can outline the important parameters and give you an approach to analyzing these tests so that you have maximum diagnostic yields. So heart rate reserve and heart rate. The normal max predicted heart rate is 220 minus your age, and normal subjects should reach greater than 80% of their age predicted maximum. And in this situation, cardiac output limits exercise capacity, and this is normal. Some patients can be anxious when they start their tests, so you might see higher heart rates at rest, but this should settle and become more linear, just as shown in the curve there, as the patient starts to exercise. Usually the heart rate maximum is at the highest point when the patient stops the test. Unfit patients and those with heart disease will also reach their max 80% max predicted heart rate, but their VO2 max will be low. Often we'll see a rapid increase in heart rate, as the only way to increase cardiac output is to increase heart rate. Heart rate reserve, on the other hand, actually looks at maximum heart rate, but from another angle. It speaks to the possibility of increasing heart rate any further when the patient is at maximum exertion. So for example, a low heart rate reserve, from the heart's perspective, the test was stopped appropriately. The cardiac output has maxed out and there's very little room to increase heart rate further. If maximum heart rate remains low or the heart rate reserve is high, the patient either didn't try very hard or something other than exercise is limiting exercise capacity. This could be beta blockers, this could be the lungs, this could be peripheral arterial disease. And then chronotropic insufficiency is also assessed at this juncture. Oxygen pulse is the amount of oxygen taken up by the lungs into the blood with each heartbeat. And so the more blood flow into the lungs, the more oxygen pulse will be taken up. Normally, the O2 pulse is increased during the early part of exercise, so as the stroke volume increases, and then tends to tail off, and further increases in cardiac output and hence VO2 is related to increasing heart rate. Normal values are greater than 10 and often greater than 15 milliliters per beat, but elite athletes can actually achieve up to over 40 milliliters per beat. The plateau will occur as the patient reaches the maximum steady. But when it happens in low values, so no 2 pulse less than 10, it implies limited cardiac output because either of heart disease or disorders of the pulmonary circulation. And in severe LV impairment, the stroke volume may not increase significantly at all, and as the only way to increase cardiac output is to increase heart rate. If in ischemia, you may see the stroke volume become suddenly impaired, although this should be correlated with ECG changes. So a caveat to the O2 pulse is that its interpretation is limited by cyanosis. Recall the Fick equation, where VO2 is the product of your cardiac output multiplied by the difference in your oxygen content in the blood and that of the mixed venous blood. The O2 content also depends on the hemoglobin concentration and the peripheral oxygen saturations of the muscles. And so in arterial desaturation, such as lung disease, a PFO opening up, or veno-vetal collateral shunting through a Fontan, the CaO2 taken up by the blood in the lungs will be low, and this results in a low O2 pulse. This is in part why athletes have a high O2 pulse, is that they are very efficient at extracting oxygen from their muscles, and so they actually can achieve a very low CVO2. Minute ventilation is the sum of all of the breaths in 1 minute, and it's a product of the frequency and depth of breathing. The volume of each breath, or the tidal volume, will increase by 3 to 4 times, up to 60% of vital capacity in younger patients. And with older patients, it should at least double. Usually, minute ventilation does not normally limit exercise, but if it gets beyond 80% predicted, exercise is limited from the lungs. And from a cardiac perspective, this patient has stopped early because of their lungs, so they haven't yet reached their maximum capacity. And as a result, the VO2 max and the heart rate will be expectantly low. The one exception to this is trained athletes who can push themselves beyond their predicted VO2 max and are limited by ventilation. And usually a CPET doesn't reveal significant lung disease that wouldn't have been anticipated on the test you would do before doing a CPET, but it's important to know the extent of the disease with respect to the exertional symptoms. In normal subjects, the tidal volume, or VT, increases with low intensity exercise. And then there's a further increase in ventilation, which is achieved by increasing the breathing rate. Patients with lung disease have a flatter slope on their tidal volume to minute ventilation plot, and this suggests that they rely more on the rate of breathing than on increases in tidal volumes, and they'll reach that plateau much sooner. If a subject's breathlessness is a problem of perception rather than true cardiac or respiratory limitation, they'll have something called dysfunctional breathing, also known as hyperventilation syndrome, and it shows an irregular increase in minute ventilation with exercise. Note, it's not uncommon for patients to have a somewhat irregular tracing at the start of exercise, but this should even out and the hyperventilation become more linear as they start to exercise. But there's no carbon dioxide in the inspired air. So looking at the concentration of this gas in expired air and multiplying it by the minute ventilation yields the volume of CO2. The link between ventilation and VCO2 is closely correlated. So more alveolar ventilation means more VCO2. And lots of ventilation without much CO2 in the expired gas implies that the lungs aren't working. Dead space refers to the segments of the airways that are ventilated but do not participate in gas exchange, either because they're anatomical, such as your tracheae without alveoli, are not perfused. And perfusion is in part due to the west lung zones, which you can see in the top right. During exercise, though, the dead space decreases and there's increased perfusion to the lungs, primarily the upper lung fields. And this is due to increasing heart rate and increasing cardiac output, as well as the VQ matching becomes more even. And so there are two important physiological sources for carbon dioxide. First is the metabolism of fuel to produce energy. And then during anaerobic metabolism, hydrogen ions from lactic acid are buffered by bicarbonate, and the result is carbon dioxide and water. Anaerobic threshold is the point at which oxygen demand from the muscles exceeds the amount delivered to them. Beyond this point, the work that is done is anaerobic, as well as aerobic metabolism is going on to a degree in the background. The VO2 max at which the anaerobic threshold is observed should be greater than 40% the VO2 max predicted. And in trained athletes, this can be as high as 80%. The anaerobic process results in more CO2 production or buffering of lactic acid. And this is seen by a slope of the VO2 curve, VCO2 versus VO2 curve graph. Quite often, the change has not such a sharp inflection point, but is more gradual. And it can be difficult to determine the exact moment of the anaerobic threshold by this graph alone. And so we have other ways to do it on a CPET. Causes of reduced anaerobic threshold are impaired delivery of oxygen to the muscles, usually because of heart disease or peripheral vascular disease, and low SpO2. Once the patient reaches anaerobic threshold, the buffering of lactic acid by bicarbonate keeps the pH normal for a while, but then acidemia develops. The carotid bodies sense this change in pH and they stimulate ventilation. And this stimulated increase in ventilation is captured graphically by plotting minute ventilation to your VCO2. This inflection point is called the respiratory compensation point and is the point beyond which there's respiratory compensation for acidemia. I recall that CO2 diffuses very quickly and easily out of the blood into the alveolar gas, and the rate of expulsion is primarily due to the PaCO2. So if a patient hyperventilates and lowers this value, the driving pressure is lower, less CO2 is inhaled, and this will change the slope beyond the respiratory compensation point. And this RCP implies maximal effort was made by the subject and usually happens shortly after anaerobic thresholds. Of note, this slope is a significant marker of morbidity and mortality, especially in heart failure patients. It implies significant VQ mismatch. Ventilatory equivalence is a unitless value, and it can be thought of how well the lungs work. Lots of air in and out without much oxygen taken up is not very good. And so the lowest point on this curve is reflective when the lungs are working their best. Once anaerobic threshold is reached, there's a point in time where muscle acidosis is effectively buffering bicarbonate, shown here, and it prevents acidemia by generating CO2. Once acidemia develops and triggers ventilation, then the respiratory compensation point is shown, at which point we start to blow off CO2. And if this ventilatory equivalent of CO2 is greater than 30, it implies high dead space, and greater than 45 is severe impairment. Finally, the respiratory exchange ratio is beyond anaerobic threshold. The RER suggests a maximum steady. And once the anaerobic threshold is crossed, more carbon dioxide production is generated from that buffering of lactic acid. whereas oxygen uptake cannot be increased further because we're at anaerobic threshold. So you can see the point of crossing of these two curves is the anaerobic threshold, and also implies that the respiratory exchange ratio has been met. So these two parameters can thought to be equivalent and are indicative of a maximal study. And so oxygen saturation is one of the final parameters we look at it as CPET, and changes of greater than 4% during exercise are abnormal. Often it's the lungs, but in our congenital heart patients, this can be related to their underlying physiology and anatomy. And so most often this can be from a right to left shunt. So you can see, hopefully, in the graphic here, these are veno-venal collaterals here from the innominate vein into the pulmonary vein in some of our patients with Fontans, and it results in significant shunt. So there are some benefits to training, which we'll go through a little bit later, but really increased training can increase your cardiac muscle, your cardiac output, and your exercise capacity. It will result in a lower resting heart rate, improved microvascular oxygen extraction, and develop those capillary muscles, capillaries to the muscles, and result in the formation of new capillaries. Overall, it should result in an increase in amino. So let's dig into some CPET cases. With cardiopulmonary exercise test results, there's a lot of data thrown at you all at once, and it can kind of feel like you're drinking from a fire hose. So I'm going to give you a bit of an approach to these graphs, which can be very helpful to give you a quick idea of the information that you're getting. And so the first three panels at the top really help see how the patient progressed through exercise. Here we have the ventilatory minute ventilation on the top left, and then the heart rate and oxygen pulse in the panel next to it. And then our VO2 and VCO2 slopes, which really gives us the first estimate if these two curves cross, if the patient reached their anaerobic threshold. And in this particular example, the patient did. The middle panels actually show your minute ventilation to your VCO2, and if there's a change in that slope, then it helps reveal an anaerobic threshold. And if I can convince you, there is a small little change there as well. The VCO2 and VO2 curves are shown in the middle as well and can help determine the anaerobic threshold. And then the plot on the far right are the plots of the ventilatory equivalents and also help show your anaerobic threshold and respiratory compensation point. And finally, along the bottom, your tidal volume to minute ventilation can reveal dysfunctional breathing. In the middle, we have our RER, which also looks at dysfunctional breathing and helps determine if there's a maximal study. And then the bottom right gives us our peripheral oxygen saturation and end tidal CO2. I'm gonna skip these for a moment and we'll come back to them later. But for our first case, so this is a very complex patient who's 26-year-old female whose original anatomy was congenitally corrected transposition of the great arteries. She had pulmonary atresia, MAPCAs, an outlet VSD, ASD, and PDA, so lots of shunting, and was ultimately palliated through many surgeries with the closure of shunts, and was left with an extra cardiac Fontan. She also had third-degree heart block and was pacemaker dependent. And prior to the study, was known to have low normal ventricular function, no significant valvular regurgitation, and then no significant shunting. So this was a bike study to begin with. She exercised just under 12 minutes, and the test was terminated due to leg fatigue. There was a slight drop in blood pressure, but it was measured too early in recovery, and her oxygen saturation was stable throughout. So I'll ask you guys to see if you can determine from the graphs, was this a maximal study? Or did the patient reach their anaerobic threshold? Everyone's formed an answer in their head. And so, yes, the RER is greater than 1. And we can see the crossing of the VCO2 and VO2 curves, usually around the 8-minute mark, in this particular example. We see that again later in the ventilatory equivalent curves, change in slope of the VCO2 to VO2, and then another change in the minute ventilation to VCO2. The remaining parameters are shown in the table here, and all of the bolded values are abnormal. Here I'll notice a relatively low workload, but the biggest perhaps finding is this really slow heart rate, suggestive of chronotropic incompetence. And I think that in this study, it might be in part because the patient was exercised on a bike and the accelerator was not activated with its rate responsiveness because of relatively small motion. This partly explains why the oxygen pulse here is very high at 182% predicted, because you'll recall oxygen pulse is your VO2 divided by your heart rate. And then the VE/VCO2 slope at anaerobic threshold is elevated, indicative of high dead space. The poor VO2 max is in part due to their heart rate, but we need to recall that this is a patient with Fontan. We can't use the normal parameters that we would for an otherwise non-congenital patient. And so we really have to go back to that chart of reference values. So when we actually take the VO2 max in this context, it's actually slightly above average for what we would expect for a patient with Fontan circulation. And so I think the biggest limitation in this particular case is the poor heart rate. And so we sent the patient to the device lab for a change in their rate responsiveness. And next time we exercise them, we'll do it on a treadmill. Their spirometry was very normal. Our second case is a little bit more straightforward. It's a patient with congenital pulmonary stenosis who had a prior surgery and intervention of a valvotomy. They were left with severe pulmonary regurgitation, moderate RV dilatation, but restrictive RV physiology, and had progression of their symptoms to NYHA class 3 from NYHA 2. Looking at their spirometry, you can see it's very normal. For their exercise on a treadmill, they were known to be obese with a BMI of 30. Their time was just under 9 minutes and 30 seconds, and this test was terminated due to shortness of breath. They had a slightly blunted blood pressure response, and notably their oxygen saturation was normal throughout. We'll give you a second to look at the graphs here to tell me if you think the patient reached anaerobic threshold and what you think their predominant driving or rate limiting step was. Was it cardiac or respiratory? So looking at the, and here, sorry, is a little bit more information for you. And so looking at the top 3 panels, there's some evidence of chronotropic incompetence. And when you delve a little bit further, this patient happens to be on beta blockers. Their peak heart rate is only 66% predicted. They have a very low workload at 46%, which may speak to some deconditioning, but also a very flat O2 pulse, suggesting that their effective cardiac output and stroke volume may be limited by their severe pulmonary insufficiency. It was maximal steady as anaerobic threshold was reached, but was low. And here the RAR also is greater than 1, confirming a maximal steady. Overall, it's consistent with early cardiac limitation. And we compare it to their prior study. You can see that there's been a significant change across the board. And I think this is one of the most important things for congenital patients, is to compare to their prior study to see any changes. The workload has dropped, her VO2 max has dropped, anaerobic threshold, O2 pulse, and then the concerning VE/VCO2 slope indicating more dead space has increased. And in patients with congenital heart disease, there are several predictors of mortality, of which the VE to VCO2 slope is one, but the caveat is that you can only use this in non-cyanotic patients. This is a study of just over 1,300 congenital patients at a single center. And they really tried to look at what factors affect mortality. And they found, in addition to the VO2 max, the heart rate reserve was relevant, and they divided their patients into cyanotic and non-cyanotic. And the predictors for these studies held in terms of mortality, with the exception of VE/VCO2 slope in cyanotic patients. They did find that this slope was useful in submaximal studies, helpful in patients who are unfit. Okay, so our third case is another Fontan. She has hypoplastic left heart syndrome, and she's training to be a ballerina. She actually won a competitive scholarship to Toronto. She was palliated with an extracardiac Fontan with a fenestration, and then underwent a fenestration device closure. She has mildly reduced right ventricular dysfunction, moderate tricuspid regurgitation, and mild to moderate neo-aortic regurgitation with a fenestration leak expected. So mixing between her systemic venous and pulmonary venous circulations with baseline oxygen saturations of 92. You can see from her spirometry that she has a minor restrictive pattern. And then for her cardiopulmonary exercise test, so she did very well. She did 12 minutes and 23 seconds, has a normal BMI. The test was terminated due to leg fatigue, appropriate blood pressure response. The notable finding here is that she desaturated. You'll also note that the top panels show a somewhat jagged appearance of her minute ventilation, possibly reflective of some disorderly breathing. And this is shown in the bottom left and middle bottom panels as well. There's a component of hyperventilation because that seems to settle out, probably just that she was anxious. And as the study progressed and workload increased, it smoothed out. Was this a maximal study? The answer is yes. We have crossing of both of the curves in the panels on the right, and our RER is greater than 1. This patient, looking at her other parameters, had a minor reduction in her heart rate of 77% predicted, but her oxygen pulse was low at 74%, but we remember that she's a congenital patient, and we actually look back at the VO2 graphs for her anatomy, and she is in the upper quartile of what we'd expect for a Fontan, so she is doing exceedingly well. You'll note that her VE to VCO2 slope is elevated, and the rationale here is because of her desaturation. So with the increased right to left shunting, it's reflective of that rather than a true exercise limitation. And so she has really done exceptional for her Fontan circulation. So just to highlight that the limitations of VE to VCO2 slope are particularly related to shunting, and it can artificially increase this value. Our fourth case is a patient, another Fontan. I don't have other details for him, but he was found to have some minor obstructive lung disease. With his graph, with exercise, you can see that he exercised just beyond 10 minutes, has a normal BMI, and the test was terminated from leg fatigue. He had an appropriate blood pressure response, but he was cyanotic to begin with and had further desaturation with exercise. Of note, this is a sub-maximal study, and he has a poor heart rate response. You can see there's no crossing of the VCO2 and VO2 curves. The RER doesn't quite make it to 1, although it gets close towards the end of exercise. And there's some disorderly breathing that settles out. You can see his parameters across the board are atrocious. So his workload is low, his VO2 max is bad, even taking into account he's a congenital patient. He has a very poor anaerobic threshold and a high VO2 slope we can't use because he's cyanotic. And surprisingly, when we look back, this is actually an improvement from what he had previously. You can see that his RER is close to maximal study, but not quite. His VE VCO2 slope has gotten better. He's always had cyanosis. But his other parameters, workload, VO2 max, anaerobic threshold, and O2 pulse have slightly improved. And so what was the intervention between 2017 and 2022? Guesses? And so I'd like to highlight some of the important parameters of why exercise is so important in these patients. And one of the highlighting features here is that this patient was exercising, and it's the reason for his improvement is the OUES. And so we haven't talked about it because it's not always reported in CPET studies, but it's really the efficiency of the peripheral oxygen uptake. And it's one parameter that combines the distribution of blood to muscles, the muscle mass, oxygen extraction and utilization, and also incorporates physiological dead space. But within the same patient whose only change was training, it actually shows that they significantly increased their muscle mass. And it's important because it correlates with VO2 max as well as NYHA functional class. And it's a surrogate marker of VO2 max and submaximal studies, such as our patient who didn't reach his maximum threshold. So the steeper the OUAS, the more efficient oxygen uptake, and it is also dependent on height and age. So switching gears, I'd like to talk a little bit about exercise in the Fontan circulation, our current philosophy and future directions. And so when we talk about Fontan, there are unique reasons why patients with Fontan palliation may benefit from exercise more so than others because of their unique circulation. So as a quick review, Fontan palliation refers to the end result over several surgeries of a complex congenital heart lesions that cannot be repaired into ventricular physiology. To alleviate the mixing of deoxygenated and oxygenated blood and cyanosis, as well as volume loading, the systemic veins, so your SVC and IVC, are connected straight onto your pulmonary arteries. This effectively removes the subpulmonic ventricle, and the heart is essentially bypassed through a conduit to the pulmonary arteries. There have been several iterations of the surgery, but the current standard of care is the extracardiac conduit shown here. And then blood, after it travels through the lungs, returns to the heart and goes out to the rest of the circulation as per norm. In Fontan circulation, there are significant contributors to exercise and cardiac output, not seen to the same degree in normal patients. So in inspiration, we generate negative intrathoracic pressure, and that sucks blood into the pulmonary vasculature. On expiration, the blood is pushed out of the lungs and into the heart. And this respiratory bellows is very crucial to blood flowing through the lungs of a Fontan patient. Skeletal muscles are also very important in the cardiac filling. And they have looked at patients with higher skeletal muscles in those legs. They have improved cardiac output with exercise because the bigger the muscle belly, the more blood is squeezed back to the heart with each contraction. And resistance training plays a crucial role in these patients. Diastolic function also influences their cardiac output, and so things that raise EDP will affect the Fontan circulation. Fontans are also noted, in addition to have complex congenital heart disease, to have associated myopenias. They have decreased skeletal muscle mass, and it's thought to be secondary to the abnormal development of the muscles, partly due to reduced blood flow and from other factors we don't understand. And in one study, up to 30% of patients were within the sarcopenic range. And this abnormal muscle function reduces the ability to extract oxygen and has impaired endothelium-dependent vasodilatation. Another critical bottleneck in the Fontan circulation is the pulmonary vascular resistance. And so you can see that for patients with relative differences in their pulmonary vascular resistance, this can significantly affect their cardiac output. So its PVR is influenced by your connections, your pulmonary arteries, the capillary network, and then the pulmonary veins and their atrial connections. So here is an echocardiogram that actually shows the Glenn connections, so the SVC connecting into the pulmonary artery. And on the right, there's the PW tracing to show this laminar phasic flow. You note its lack of pulsatility in the vascular bed, which is contrary to all of the people in this room who would normally have pulsatile pulmonary artery flow. And so there was one study that actually looked at patients with exercise and what the flow profile of these Fontan patients had when they were exercising. And so the top panel is normal Fontan physiology in the pulmonary artery. And in the bottom, you actually have patient exercising. And you can see the green line actually was attached with transducers to the leg. So we get a sense of when each muscle contracts. And with each muscle contraction, we're pushing blood into the lungs, augmenting the cardiac output. So does exercise really matter in these patients? It's a small body of data that we have to go off of. And there was one review study that looked at over 240 patients with exercise training reported in the literature. And they found that VO2 max was improved following an exercise regime, and it correlated with improved clinical outcome. And those patients who can maintain their exercise capacity or improve it over time do much better than those who can't. So compared to some of our classic medications for Fontan patients, you can see that exercise in these two studies does far superior to ACE inhibitors or sildenafil or bosentan. And the largest study that we have is actually 42 patients. That was the one by Turcotto, which looked at aerobic exercise, but a short period of follow-up, only 4 months. And it showed significant improvements in peak VO2 in exercise groups. Our final case is a 50-year-old male. He's got bicuspid aortic valve, coarctation, a subarterial VSD, and a subaortic ridge. He underwent VSD closure, ridge resection, resection of the coarctation, and then an end-to-end anastomosis. He was left with moderate to severe aortic insufficiency, an ascending aortopathy, but no residual coarctation or aneurysm. His spirometry shows a restrictive pattern, obstructive pattern, and unknown if asthma or COPD. And then his curves show that he was very hypertensive with exercise with a blood pressure of over 210, but maintained oxygen saturations throughout and actually went just under 15 minutes. Test was terminated for leg fatigue. And you can see while his heart rate is low, the thing that actually limits his exercise here, and it was a maximal study, is his ventilation. So his minute ventilation is 90% predicted. And so this was one of the few cases that we see often in the cardiac clinic where it's a respiratory limitation. And so I'd just like to quickly talk about hypertension with exercise. So if a patient's known to have resting hypertension, exercise, testing the patient to look for exercise-induced hypertension is not helpful. You really want to see those patients that are normotensive and then have an exaggerated blood pressure response, which is typically defined as greater than 210 or 190. And in one Dutch study, the Concours study of just under 700 patients, they looked at patients with coarctation who were repaired, who didn't have residual coarctations, and they found that 35% of those patients developed a hypertensive response when they were normotensive at baseline. And this had significant implications. It was mostly predictive of developing future hypertension, increased risks of death and CV events, and then angiographic coronary artery disease as well. And so when we come to having these patients, we've done a cardiopulmonary exercise test, and then we're trying to figure out what to tell these patients to be more active. This is a recent article from CJC that really tries to quantify the patient's risk into low, intermediate, or high based on their systolic and diastolic dysfunction, their valvular function, outflow tract obstruction, arrhythmias, and their aorta. And you'll use for each of those categories, the risk that's the highest is the one that you'll follow for exercise. While there's no magic formula for exercise, we typically like to incorporate aerobic and resistance training, with resistance training focusing on developing those large muscle bodies, particularly in the leg, and especially for our patients with Fontan circulation. And although a heart rate monitor is not essential, it can be a very powerful tool to allow for motivation and precise prescription of aerobic exercise prescriptions. And so what you're going to recommend to patients is a heart rate maximum that's derived from their baseline exercise testing, not what their predicted heart rate should be. It's what they actually were measured to have on that CPET that you did. The heart rate reserve is another parameter to use, but I find more challenging than in the clinical setting. And the RP here is the perceived relative exertion with the Borg scale, which is also, I think, challenging in clinical practice because there's so many points to it. To allow for resistance training, we ask patients to do pushes and pulls of each about 2 seconds. And the less exercise you do in a set, the harder it is. So technique is really important here. So because Fontans in particular rely so crucially on the thoracic pump and breathing, their cardiac output can fall off significantly with Valsalva. And so we want patients to breathe continuously. And so here's kind of a typical resistance training recommendation we might make for patients that you can see based on their risk. We want them to target at least 150 minutes of activity per week with 2 resistance training sessions. And there's some data to suggest that actually handing someone a written prescription for exercise like you would with a medication increases their activity level. You're going to want to comment on the frequency, intensity, how long each exercise should last, and what type of aerobic or resistance training you'd recommend. The ESC 2020 guidelines show an idea of what certain activities are for exercise, but we've all seen that beer league hockey player who's determined to make the NHL draft and the other person who's just on the team for the beer itself. And so I find activity just based on the mode of exercise is not the best marker. The Borg scale is listed here, which is very complex and hard for me to remember, so I don't know how a patient would. But in describing exercise intensity, the easiest way I find is light intensity is when you can speak in a sentence without being short of breath. Moderate intensity is when you can speak in a sentence or mildly short of breath, and it would be difficult to sing. And then high is when you are unable to complete a sentence without taking a complete breath or using a breath every few words. And so in conclusion, exercise is very important lifelong implications that can be extended to ACHD patients. Cardiopulmonary exercise testing is a powerful tool to differentiate between cardiac and respiratory causes of dyspnea. And we have different reference values for ACHD patients. Our VO2 max, our heart rate reserve, the VT slope indicate mortality, and the VEV CO2 slope and OUAS can be used in submaximal studies. And I would advocate as an exercise prescription for all patients. So with that, I would just like to thank my old program director, Dr. Rafa Alonso Gonzalez, Dr. Daniel Viz, who's a local respirologist here, and Dr. Beatrix Fernandez Campos for their help with this talk. I'd also like to acknowledge the generous support of the Arthur J. Childs Scholarship Fund and the Helios Scholarship. And with that, I'll turn it over to any questions.
Open up the chat line for people online. If they want to ask in there, that would be great.
Really great question. I'm a little bit biased, and I think the congenital patient would be the benefit from that intervention, because hopefully for the parameters that I've outlined, where there can be so much more at play, not just their congenital heart disease, but almost half of them have underlying pulmonary function abnormalities at rest, and then all of the other muscular abnormalities that can come, like the myopenia and Fontane's, sussing out what part of their symptoms are related to what aspect of their physiology can be helpful, and it has such important implications for them living with heart disease their whole life, and so they're not very good at picking up small changes. Most of them aren't great athletes. Sean White is an exception, and so having that objective marker that you can look at year after year can really highlight more subtle changes. I think it has wide implications beyond congenital heart disease, but I really see its value in that population. Yeah. I think it would certainly help actually quantify what her degree of obstruction is. Some patients with pulmonary vein stenosis can be significantly symptomatic, but I haven't seen it actually commonly. So I think it would be helpful in also proving that there's not another etiology for her dyspnea, and then also giving you a quantification of exactly how bad that limitation is for her. Yeah. Yeah, it's a good question, one that I don't have a great answer to. So it used to be done primarily at the Lougheed and the Rocky View. And since I came back from Toronto, they're only doing it at the Rocky View due to staffing issues. I'm not sure what the capacity would be to take it back on at the Lougheed. Certainly they have all the equipment there and they have staff that's trained in it. But my understanding, it was a barrier in terms of lack of supervision. And so perhaps, if I'm fortunate enough to come on a staff, I could help with that aspect, but it's just at the Rocky View now. And there's a significant delay to getting tests. It's a couple weeks to months. They do a great job. Yeah. Oh, has the wait list gone down? Yeah. They do a fantastic job. It was way more detailed, the reports that I get here, than what I got in Toronto. Yeah. 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 Does, yeah. And so you'd expect like your VE to VCO2 slope to be higher in those patients. I guess if you had an interval study where suddenly their V/VCO2 slope goes higher, you're wondering, are they still having that event? Are they compliant with their anticoagulation? But you're right, with you have combined factors like diastolic function, that can confound the waters a little bit. But I think that the extra utility that you'd get from the parameters that you see on the CPET might help separate that out a bit further. Yeah. Thank you very much. Thanks for having me.